Name is Brandy Holcomb. I'm an adult geriatric acute care nurse practitioner student with the University of Texas at El Paso, presenting a case presentation on a patient admitted with salicylate toxicity. Been called to the emergency room to Trauma 1 to evaluate a 39-year-old female Caucasian patient with an intentional salicylate overdose. TW is a 39-year-old female patient with a history of anxiety disorder and seizure disorder. She currently takes Tegretol and Dilantin. She presented to the emergency room at 06:30 this morning by EMS following an intentional salicylate overdose. She reported to EMS that she took 40 tablets of 325 milligrams enteric-coated aspirin. She took 2 tablets, 0.5 milligrams of Klonopin, and an unknown number of Benadryl tablets. According to the emergency room physician, this patient was mildly lethargic on arrival, and her mental status deteriorated rapidly to the point of requiring endotracheal intubation for airway protection. Admitting blood pressure was 150/110, heart rate tachycardia 134 with a SpO2 of 90% on a non-rebreather. She was breathing tachypnic at 35 respirations a minute. The patient vomited prior to intubation. She was unable to give a history related to her altered mental status. Currently, her mother is at the bedside and is considered to be an appropriate historian. The patient received 50 milliequivalents of bicarb by EMS. In the emergency room, she received another 50 milliequivalent amp of bicarb, 1 amp D50, 1 liter of normal saline for fluid resuscitation, and 50 grams of activated charcoal via NG tube. Initial salicylate level was 73 milligrams, and initial blood gas was pH 7.46, her bicarb level 18, a CO2 level of 23, and a PO2 of 370. Urine drug screen was positive for barbiturates. She is to be admitted to the to the ICU for critical care management. As this patient was intubated on my initial exam, a review of systems was unable to be performed for relevant and subjective review. Constitutionally, she weighs 90 kilograms and is 66 inches in height. On physical exam, her vital signs were blood pressure 126/81, sinus rhythm 97 beats a minute, ventilated rate of 24 respirations a minute, 98.5 degrees Fahrenheit, 98% on mechanical ventilation. Ventilator settings are mode PRVC, FiO2 of 40%, respiratory rate of 24, tidal volume of 500 milliliters, and a PEEP of 5. This patient appears well developed, yet appears distressed. She is intubated and sedated. Pupils are equal in size and reaction, yet sluggish to light. She has a nasogastric tube secured to the right nair, and she is endotracheally intubated. Neck is supple, trachea was midline, no masses or nodules are palpated. Neurologically, she is sedated. Thoracic expansion was symmetrical with mechanical ventilation. Tachypnea is noted. Breath sounds were coarse to auscultation with noted anterior rhonchi and diminished sounds in the bilateral bases. Cardiac PMI impulse is noted to the 5th intercostal space left of the midclavicular line. Tachycardia is noted to the bedside monitor. S1 and S2 are normal. No more murmurs are auscultated. Her abdomen is non-distended. Bowel sounds were present to auscultation in all 4 quadrants. Spleen and liver are non-palpable. Abdominal aorta is clear to auscultation. No bruit was noted. There is a Foley catheter in place with a minimal amount of amber-colored urine. No drainage or mucus noted. No cyanosis or clubbing is noted to her peripheral extremities. No edema and peripheral pulses are palpable. Her skin is warm and dry and intact. Bruises are noted bilaterally to her forearms. Initial diagnostic studies. An initial chest x-ray reads there is a new right internal jugular central line that terminates into the distal SVC. Support apparatus is otherwise stable. Endotracheal tube is appropriately noted above the carina. Mediastinal and hilar silhouette is stable. Lung spaces and pleural spaces are stable. There's no evidence of pneumothorax. The osseous structures and soft tissues structures are stable as well. Renal ultrasound has been performed. The clinical indication, acute renal failure. The findings, right kidney measures 10.7 by 4.9 by 4.9 centimeters and demonstrates normal contour. Left kidney measures 9.9 by 6.1 by 5 centimeters and demonstrates normal contour as well. There is normal renal cortical thickness. No hydronephrosis is noted. Differential diagnosis for TW are 1. Acute respiratory failure, 2. Salicylate toxicity, 3. Acute kidney injury, 4. Aspiration pneumonia, and 5. Mixed respiratory alkalosis and metabolic acidosis. Plan for this patient's management. For acute respiratory failure, mechanical ventilation will be continued with the above stated settings. We will monitor serial arterial blood gases, daily chest x-rays, bronchodilation with Atrovent nebulizers Q6 hours and PRN as needed. We will also place an arterial line for optimization for ABGs. Salicylate overdose. Initial fluid resuscitation with isotonic saline at a rate of 15 mils per kilogram times 3 hours. Then we will titrate to maintain urine output of 2 mils per kilogram per hour. We will dose activated charcoal 50 milligrams every 4 hours for 2 doses total. Sodium bicarb drip, 150 milliequivalents in 1 liter of D5W at 200 mils an hour. We will monitor serum K levels every hour. We will monitor urine pH every hour. Monitor salicylate levels Q1 hours. These levels should coincide with the ABG until salicylate concentration is falling and the acid-base status is stable or improved for 2 consecutive measurements. We will also consult regional poison control for further guidance. For her acute kidney injury, there will be placement of a central line in expectance of hemodialysis for salicylate clearance. We will consult nephrology, monitor serial renal panel, and hemodialysis for salicylate clearance per nephrology. For aspiration pneumonia, we will monitor sputum cultures and provide empiric coverage for gram negatives and anaerobes with IV Zosyn, Q6 hours. We will apply subglottic suction to the endotracheal tube. For the mixed respiratory alkalosis and metabolic acidosis, we will continue the sodium bicarb drip of 100 milliequivalents in 1 liter D5W at 200 milliliters an hour. It is interestingly enough to note alkalemia from a respiratory alkalosis is not a contraindication to sodium bicarbonate therapy in these types of patients. Aspirin poison patients commonly present with an arterial pH between 7.50 and 7.55. These patients should be treated with sodium bicarb. We will continue to monitor arterial blood gases. In summary, this is a 39-year-old female patient with an attempted suicide by salicylate overdose. She will be admitted to the critical care unit for salicylate toxicity, acute respiratory failure, acute kidney injury, aspiration pneumonia, and a mixed respiratory alkalosis metabolic acidosis. We would like to thank the emergency room physician for this consult to critical care. Thank you.